My name is Carrie Deal, and I'm the PGY2 Critical Care Pharmacy Resident at Vidant Medical Center in Greenville, North Carolina. Today, I will be sharing with you my research on the safety of various dosing strategies of 23.4% sodium chloride for intracranial hypertension. Neither myself nor my project mentors have anything to disclose. Vidant Medical Center is located in Greenville, North Carolina. It is licensed for 974 beds with approximately 45,000 annual admissions. We are a Level 1 adult trauma center and have a neuroscience intensive care unit with 32 beds. Intracranial hypertension is increased intracranial pressure, which is a known complication of ischemic and hemorrhagic strokes. Elevated intracranial pressure decreases brain perfusion and can result in permanent neurologic damage and then death. The treatment of intracranial hypertension is multimodal, and you'll see that osmotherapy is included in both acute therapy options and maintenance therapy treatment options. The osmotic agents are hypertonic sodium chloride and mannitol. The hypertonic sodium chloride in this study was 23.4%, which is usually dosed 30 to 60 milliliters or 1 to 2 vials, given through a central line or intraosseous. The advantages of 23.4% sodium chloride is less total volume than 3%, which allows for rapid administration. The large safety concern, which greatly limits its use, is concern for osmotic demyelination syndrome, which occurs when serum sodium increases rapidly, damaging nerve cells' myelin sheath. What is unknown about 23.4% sodium chloride is will larger doses be more effective in reversal of brain herniation, and does that benefit outweigh the risk of osmotic demyelination syndrome? Pictured on the right is our brain box, and it's our emergency kit located in the neuroscience ICU, and it contains 4 vials of 23.4% sodium chloride. The purpose of this study is to add to existing literature by investigating the safety concerns of using various doses of 23.4% sodium chloride for acute treatment of intracranial hypertension. This was a single-center retrospective cohort from November 1st, 2018 through October 31st, 2019. Patients were screened by doses of 23.4% sodium chloride from the brain box. The sample size was approximately 100 patients, which was determined due to previous studies of similar nature. We included adult patients with a primary diagnosis of hemorrhagic or ischemic stroke with clinical signs of intracranial hypertension that received at least 1 dose of 23.4% sodium chloride from the brain box. We excluded patients who received hypertonic saline other than 23.4% at the time of admission, patients receiving mannitol at time of admission, and patients who received their first dose of 23.4% sodium chloride more than 24 hours after their admission. Our primary outcome was a change in serum sodium greater than 8 milliequivalents following the initial dose of 23.4% sodium chloride. We chose 8 milliequivalents as our goal because a change greater than 8 milliequivalents in a 24-hour period is generally considered unsafe. Our secondary outcomes included clinical signs of osmotic demyelination syndrome determined by provider, reversal of brain herniation, length of stay in the ICU, and survival to discharge. Our baseline characteristics are analyzed with descriptive statistics. Nominal data will be analyzed using chi-square test, and predictive variables for increased sodium will be analyzed using a Cox proportional hazards regression model. Statistical significance is defined as a p-value less than 0.05. 426 patients received doses of 23.4% sodium chloride. After excluding 322 patients listed in the pink boxes, we ended with a final patient population of 104 patients. Our patient population was split into 2 groups. The first group received 2 or less vials of 23.4% sodium chloride, which would be doses of 30 or 60 mLs, which stated previously is the generally accepted dose of 23.4% sodium chloride. The second group of patients received more than 2 vials, or doses greater than 60 mLs, and the dosing strategies received are located underneath this chart. Also, in the patients who received more than 2 vials, most of those patients were admitted to the hospital for hemorrhagic stroke. Our primary outcome of increase in serum sodium greater than 8 milliequivalents was more likely to occur in patients who received more than 2 vials of 23.4% sodium chloride, and this was determined to be statistically significant. The regression analysis for increase in serum sodium found 3 variables were likely to contribute to an increase in sodium. Those were larger doses of 23.4% sodium chloride, a lower baseline serum sodium, and intraosseous route of administration. For secondary outcomes, there were no patients in either group that experienced osmotic demyelination syndrome. Survival to discharge was greater in the patients that received more than 2 vials of 23.4% sodium chloride. For brain herniation, it was only present in 39 of our patients out of our total 104 patient population. And this was due to a lack of documentation of pupil sizes on admission to the hospital. Of the patients who presented with brain herniation, the patients that received 2 or less vials were more likely to have reversal of their herniation, and this was determined to be significant. The limitations of this study were that it was a retrospective study with a single-center design. Unfortunately, like I've mentioned previously, lack of consistent documentation was a great limitation of ours. Due to the emergent nature of these patient interventions, their exact timing and neurologic exams are usually charted retrospectively, and there is lack of consistent documentation within the health record. Also, we did not stratify our patients by severity of stroke on presentation. My conclusion is higher doses of 23.4% sodium chloride were linked to a significant increase in serum sodium. However, most patients in this study did not have a significant increase in sodium greater than 8 milliequivalents. No cases of osmotic demyelination syndrome occurred regardless of dose, and patients receiving more than 2 vials of 23.4% sodium chloride had an increased survival to discharge. The self-assessment question is, what routes of administration have data to support safe administration for 23.4% sodium chloride? Central line, peripheral line, or intraosseous? The answer would be central line and intraosseous. My project advisors are Jennifer Wilson, April Quidley, Dr. Markandaya, and Dr. Quinn. Thank you for your time. I look forward to answering any questions you have.